Thank you very much for having me here to talk about osteoarthritis, one disease, one many causes. I would like to thank Professor Alessandro Halpenthal for the invitation. And in the following, I will try to explain to you a little bit about osteoarthritis and about some of the common causes that might be associated with osteoarthritis. I would like to acknowledge that I'm from the University of Calgary and also this year at the Federal University of Santa Catarina here in Florianópolis, Brazil. So the way I would like to talk about this particular topic is that I first introduce what I mean by osteoarthritis, and then I will talk about some of the causes of osteoarthritis and some of the research we have done in this area, including post-traumatic osteoarthritis, muscle weakness and imbalance causing osteoarthritis, and obesity and metabolic syndrome. There are, of course, many other causes for osteoarthritis. For example, age is a risk factor, genetics are a risk factor, and also sex is a risk factor. If you are a woman, you're more likely to become osteoarthritic compared to a man, but these last few risk factors are not really controllable, and therefore I will not talk about them, whereas these three risk factors are controllable and modifiable. And so I'll be talking about them and the research associated with them. But let me start out first to talk a little bit about osteoarthritis. What is it? Well, osteoarthritis or arthritis comes from the word arthro, which means joint, and itis, which means inflammation. So it's some kind of a joint inflammation. It is associated with degeneration of joint cartilage and the underlying bone, and clinically speaking is associated with pain, stiffness, swelling, redness, reduced function, reduced quality of life, and also often affects the mental health of people suffering from osteoarthritis. In humans, osteoarthritis primarily affects the hip, knee, and the finger joints. In Canada, where I'm originally from, 1 out of 5 people is affected with osteoarthritis. There is currently no cure for osteoarthritis. It has big social implications, particularly because many osteoarthritis sufferers are cared for by family members, and it's associated with a tremendous amount of cost to the healthcare system and also for compensation for lost time at work, because people with osteoarthritis cannot come and work properly. Here we have an example of a knee joint deformation that is caused by osteoarthritis. And here we have an example of swollen and red finger joints that is also caused by osteoarthritis. Schematically speaking, osteoarthritis looks like this. So here we have a healthy joint, and here we have an osteoarthritic joint. And in osteoarthritis, there's a loss of articular cartilage that forms at the end of the bones. There are bone spurs, also referred to as osteophytes. And then very often this is associated with a narrowing of the joint space, and that is typically seen on clinical x-rays and is identified by clinical x-rays. So let me go to the first topic, the post-traumatic osteoarthritis. What do we mean by that? Well, post-traumatic osteoarthritis is a form of osteoarthritis that follows an injury to the joint. Up to 50% of the osteoarthritis cases in Canada are based on post-trauma. That means the joint was injured first, and then the osteoarthritis followed from that and was directly related to the injury. For example, in the knee joint, that can be an antiocclusive ligament tear or a meniscus injury. In Calgary, where I'm from in Canada, there's a lot of downhill skiing in the Rocky Mountains, and many people who have antiocclusive ligament tears due to cross-country skiing and also due to downhill skiing. Here we have an animal model of an anterior cruciate ligament transection. Here is the anterior cruciate ligament. It goes from the posterior part of the femur to the anterior part of the tibia. And when it's cut, as for example shown here, then we see that osteophytes form, that the medial collateral ligament increases in width, and also the medial part of the joint articular surfaces. And then after 2 years approximately, we see very distinct holes in the articular cartilage. So there's severe cartilage erosion from the medial tibial plateau in this particular example. And here we have a histological slide that shows a break of the nice surface area of the joint here in the tibia of a rat. And here you also see fizzling out and the destruction of the meniscus in this particular knee joint of a rat. So when we did a first study on post-traumatic osteoarthritis, we did this through anterior cruciate ligament transection in cats. And we were interested in what happens to the muscle forces, the muscle activation, cartilage thickness, cartilage property, and to the contact properties in the joint when you cut the anterior cruciate ligament in a cat type of a model. In order to measure the forces, we use these buckle type tendon transducers where you have a strain gauge here on top and at the bottom. And when you have a tendon that goes through this buckle and force is exerted by the muscle, then this sensor deforms, and that can be measured by the strain gauges, which then is transmitted via these cables to a recording unit. For the patellar tendon, we used a different type of a design of a force transducer. We have a kind of like an omega shaped, what is called an implantable force transducer. It's called implantable because this force transducer goes directly into the patellar tendon, as shown here, into a little pocket. And when force is exerted by the muscle, then this pocket narrows, the transducer is crushed and flattened. And by having strain gauges on top and the bottom of the transducer here and here, we then see a change in strain that then can be transferred into a corresponding force by appropriate calibration of the transducer. Here we have a buckle type tendon transducer on the medial gastrocnemius tendon of a cat, and you see how the tendon weaves through a particular buckle transducer. This is an illustration of the electromyographic electrodes, the EMG electrodes that we use. This is Teflon coated wires. We remove the Teflon coating at the last millimeter of these wires at two ends, get a bipolar electrode. Here we have a suture, and with this suture, we pull this electrode inside the muscle of the animal. We fix it inside the animal, and then can do chronic recording of electromyographic activity. And so here, for example, you have an instrumented cat that's walking on a treadmill, and you see that we have here 4 forces and 4 corresponding electromyographic signals that we measure in this walking animal. And we can do that before and after anterior cruciate ligament transection. So here are some results. So these are gastrocnemius forces and quadriceps forces. On the left-hand side here, we have before anterior cruciate ligament transection. And here we have the corresponding forces on the right-hand side, 2 weeks after anterior cruciate ligament transection. And you can very easily see that the force here, which is about 12 to 15 newtons as a peak, is about 5 newtons, so it's vastly reduced. And similarly, the quadriceps force from about 150 newtons is vastly reduced to about 50 newtons here. So you lose about 2/3 of the force very shortly within surgery of removing the anterior cruciate ligament. We also, as I said, measure the electromyographic activity. And here is, for example, the vastus lateralis, EMG. And as you can see, during the stance phase before anterior cruciate ligament transection, we have a continuous signal, whereas after the anterior cruciate ligament transection, again 2 weeks after, we have this very distinct onset and offset, these very distinct bursts of electromyographic activity that are not continuous and then cause these jaggedy spikes that you see here, these jerky forces in the quadriceps muscle. We also looked at some of the knee flexor muscles. Here, for example, the semitendinosus, EMG. And as you can see, before anteocclusive ligament transection, we have one big burst here, and the big burst here, and the big burst there. And this big burst is also always associated with the end of the stance phase. Whereas after anteocclusive ligament transection, as shown here, not only do we have a burst at the end of the stance phase, but we also have a burst at the beginning of the stance phase, as shown here, and here, and here, and here, indicating that the semitendinosus muscle is active right at the beginning of the stance phase. And the semitendinosus going into the back of the tibia will pull back the tibia at this part of the stance phase, and therefore essentially fulfill the role that normally the anteocclusive ligament had. So we think that this extra activation that we don't see before anteocclusive ligament transection is associated with keeping the tibia in place and not letting it slip anteriorly compared to the femur, as happens in other animals, including humans, when the anteocclusive ligament is gone. We also measure the ground reaction forces here before anteocclusive ligament transection, and here 1 week and 3 weeks and 3 months, up to 12 months after anteocclusive ligament transection. And you can see very clearly that 1 week after anteocclusive ligament transection, the vertical ground reaction force is much smaller compared to the contralateral limb where the anteocclusive ligament was left intact. And this stays significantly lower in the experimental hind limb for about 3 months. Until then, at least statistically speaking, the two hind limbs bear the same amount of force again. So from this particular study, we concluded that muscle forces and coordination patterns are completely changed following the anteocclusive ligament transection, but this only seems to be the case for the short term. After about 3 to 6 months, forces in the muscles and ground reaction forces and EMG activities seem to become normal, but nevertheless, the osteoarthritis still progresses and reaches end stage. After a few years, we have found that in this animal model, you clearly have end stage osteoarthritis. And then the question becomes, why is this? I mean, the forces are normal, the loading is normal, the movements are normal. Why should that be? And we speculated that it might have to do with changes in the load transmission across the joint. So we hypothesized that load transmission across the joint might be altered following anteocclusive ligament transection. And therefore, despite the fact that the movement and the forces are the same, the way load is transmitted across the joint would be dramatically changed because of the anterior cruciate ligament loss in this particular animal. So in order to test that, we used pressure-sensitive film that we put into the patellofemoral and tibiofemoral joints of these animals and then measured the contact pressures. So here we measure the contact pressure of the patellofemoral joint before anteocclusive ligament transection, and here about 16 weeks after anteocclusive ligament transection, for exactly the same amount of force produced by the muscle and for exactly the same amount, the same joint configuration. And as you can see, here we have a very dark area which indicates high peak pressures, which we don't have. The highest peak pressure is much lower here. And this area, as you can visibly see, is much smaller than this particular area. And we did this in 38 independent observations and found the same result. And when we statistically looked at that, then we found that the contact area in the patellofemoral joint was increased by about 22% on average, and the peak pressure was decreased by about 50% on average 16 weeks post anteocclusive ligament transection compared to before we had the anteocclusive ligament transected. And so the question then became, well, why is that? And we wanted to see what happens structurally in the joint, because obviously the force transmission in the joint had been changed despite the fact that we used the same force and the same joint configuration in all these measurements. And the big difference was that in the experimental hind limbs, as shown here in green, the cartilage thickness, which is shown here on the vertical axis, is much greater, so thicker cartilage compared to the control animals and the control sites that we tested. And on average, the retropatellar surface cartilage was approximately twice as thick as in the control animals. The other properties, the other mechanical properties, were approximately the same. So then we built a theoretical model where we had two cylinders pressed against one another with a certain amount of force, and we put in the articular cartilage property of the normal cartilage and of the diseased cartilage, and then measured peak pressure here on this axis, and we measured the contact radius, which represents the area on this axis. And then we found that in the theoretical model, we found that for the normal cartilage, we get a high peak pressure, and for the diseased cartilage, we get a low peak pressure because of the increased thickness of the cartilage. However, because of the increased thickness, we get also a bigger radius and therefore a bigger contact area in the diseased cartilage compared to the normal cartilage. So it has appeared from this theoretical consideration that the experimental results could be explained by the increase in cartilage thickness following the anterior cruciate ligament transection in this particular animal. So we concluded from this study that load transmission across the joint is completely changed within a very short time following the anterior cruciate ligament injury. And we also concluded that despite establishing normal locomotion kinetics and kinematics, and despite the fact that the knee joint forces were the same, the knee joint loading, the load going across the joint, was significantly altered because the articular cartilage had significantly altered in the 4 months following the anterior cruciate ligament transection. So the second cause for osteoarthritis that I would like to very briefly address is what we call muscle weakness or muscle imbalance. And just a little bit as a background, we asked ourselves the very simple question: is quadriceps muscle weakness the cause or the result of knee osteoarthritis? It has been observed in epidemiological studies that people with knee osteoarthritis have weaker muscles than a control group that is a corresponding age and corresponding sex. And so the question then becomes, are people that have weak quadriceps muscle at risk for developing knee osteoarthritis? Or when you have knee osteoarthritis, do your muscles become weak? Which is the cause and which is the effect? So we hypothesized that muscle weakness is the independent risk factor for the onset and the progression of knee osteoarthritis. And in order to test that, we used a model where we injected into the quadriceps muscles of New Zealand white rabbits, we injected botulinum toxin type A, or short Botox. And as some of you might know, Botox is an acetylcholine inhibitor and therefore does not allow for muscle activation, or only to a reduced amount depending on how much Botox you inject. In our particular case, we injected 3.5 units per kilogram of animal at the injection site in the quadriceps muscles, and that reduced consistently the muscle strength by about 70%. So the animal was left with about 20 or 30% of the initial strength. So it's a very severe muscle weakness that we produced, but we didn't completely paralyze the muscles, as has sometimes been done in other studies. And so we had a control group that received a saline injection, so an equal amount of fluid with saline that's completely harmless. And then we had animals that received Botox injection, and we evaluated them at 1 month, and other animals at 3 months, and other animals at 6 months following the Botox injections. And here you see an example of what Botox injection does. So this is the quadriceps, the four quadriceps muscles of a non-injected animal, the contralateral limb of the animal where we have Botox injections here. And here, for example, you see this is the big vastus lateralis, which is the biggest muscle in the rabbit quadriceps group. And here, this is, of course, already after 1 month, significantly smaller in the vastus lateralis that was injected with Botox compared to the contralateral corresponding muscle. And when we look at muscle weakness, given here on the vertical axis, at different joint angles, 80 degree, 100 degree, and 120 degree, then we see that there is a decrease in strength in the Botox animals. So here, about 70% loss of strength, 80% loss, whereas on the contralateral side and in the control animals, there was no significant loss in strength at any joint angle and also across time. We could verify that the loss in strength and the weakness was persistent across the entire 6 months testing period. And when we opened up joints, then we saw discolorization, slight redness, and also some surface roughness on the tibial plateau and other parts of the knee joint as shortly as 4 weeks or 1 month after the Botox injection and the muscle weakness was induced. And when we looked histologically at the muscles, we saw a very distinct difference. Here we have a control muscle where the dark area indicates contractile material and the white area indicates the muscle matrix. So like the fascial layers and the epimysium and perimysium. And here we have an experimental muscle, and you see by eye that the contractile material, the black part, is much less compared to here. And also that there is a lot of white, and this is primarily fat invasion into this particular muscle. And so this is a much weaker muscle compared to that one. So not only did we weaken the muscle, but the histology also of the muscle changed significantly. But what about the joint? What about the osteoarthritis development? We evaluated that using Mankin scores, and a higher score is worse. So a higher score means there is more osteoarthritis. And we looked at the Mankin score here at 4 weeks following the Botox injection. And we see that in the experimental animals, they have a score in this particular area of 2.3 to 2.6 from 12 animals. And then the control animals, they have a score, the lowest score 0.5 and the highest score 1.6. And these were 8 animals these were the control animals and these were the experimental animals. And as you can see, the highest score here, or the worst knee joint damage in the control animal, is less than the lowest score in the experimental animal, meaning each of the 12 experimental animals had a worse score and worse knee joint compared to the corresponding control animal. Needless to say that this was a highly statistically significant result. And we found, therefore, that and concluded that muscle weakness is an independent risk factor for the onset of osteoarthritis at 1, 3, and 6 months. I only showed you the 1 month result, but the same was true at 3 and 6 months. So we then also wanted to look at not only muscle weakness in general, but also muscle imbalance. And the reason for that is that people have argued that an imbalance of the quadriceps muscles might be a risk factor for the development of osteoarthritis in the knee joint. And so here, rather than injecting the entire muscle group, the entire quadriceps group with Botox, we induced just the vastus lateralis weakness by injecting Botox into the vastus lateralis. And then we had a control group and the Botox group. And we looked at them, 3 months after the Botox injection. And here I just want to show the similarity between a knee joint in humans and in rabbits. So here we have the vastus lateralis, and that's here going into the lateral side of the patella. And here we have the vastus medialis going into the medial side of the patella, and the same is true for the rabbit as well. So very similar kind of a anatomy in the human knee and the animal knee. And so here we look at muscle mass, and we look at this particular graph here, because this is the Botox injection, and this is the experimental muscle mass that's only about half of the contralateral muscle mass. So the Botox injection did its trick, and it reduced the muscle mass, and it kept that particular muscle weaker, although we could not measure directly the force in that individual muscle, but the size suggests that the force was dramatically reduced. If we now look at some histological slides, and I would like you to focus just on the slides here on the right-hand side, which are blown up from the ones here. And in the control animals, we largely have a nice even staining and a nice distribution of the articular cartilage chondrocytes, the cells. Whereas here in one Botox animal that received a score of 8, we have surface damage and some crack here. We have accumulations of cells. And here, and another animal that got a high score because we have surface damage here. We have accumulation of cells. The staining is not uniform, and therefore this particular animal had a high score, or in other words, bad knee osteoarthritis compared to control. So again, if you look at the Mankin scores, and these are the regular Mankin scores now, and again, I remind you, higher score means worse. So in the experimental animal, we had a range where the lowest score was a 9 and the highest score was a 13 in 8 animals. And then in the control animals, where we had 6, the highest score was a 7. So as before, the highest score here was lower than the lowest score here. That means each animal in the experimental group had a worse knee joint or more osteoarthritis than the control animals. Again, highly significant, statistically significant result of a difference. So we concluded from this particular result that a chronic imbalance induced by vastus lateralis weakness produced osteoarthritis in the patellofemoral and tibiofemoral joints of these New Zealand white rabbits. And finally, the third cause that I would like to talk about is obesity and metabolic syndrome as a potential cause for knee joint osteoarthritis. So we know that obesity is a big problem around the world. Here you see some countries that are listed with the obesity percentage. So a small island nation called Nauru near Australia has an obesity of 61% of the population. In the United States is about 36%, in Canada about 29%, and then in South America we have Chile and Brazil with 28 and 22%. And then there is countries where obesity is not that big a problem. For example, the lowest ranked or the best in terms of obesity is Vietnam at the moment, with only an obesity rate of about 2%. However, in North America in the 20s and 30s, and in South America in the 20s here, obesity obviously is a significant problem. We also know that obesity is associated with a variety of comorbidities. For example, type 2 diabetes, high blood pressure, heart disease and stroke, some types of cancer, metabolic syndrome. And recently, we and other people have also shown that obesity is associated with the onset and progression of certain musculoskeletal diseases, including osteoarthritis. So the question that we had in our first study was, again, a very simple question. Is osteoarthritis associated with increased body mass? And in order to test that, we developed an animal model where we wanted to compare knee osteoarthritis in obese animal and in normal weight animals that have a similar weight, so that weight would be the same, but the body fat percentage in how we measure obesity would be distinctly different. And the way we achieved this is as follows. We took rats and exposed some of the rats to a high fat and high sucrose diet. 45% of the diet is in sucrose. And then we also had a control group that received the regular diet that these rats receive, that is much lower in fat and much lower in sucrose. And we followed these animals for 28 weeks on this particular diet. So the primary outcomes that we measured were the body weight, the body fat percentage using DEXA, knee osteoarthritis using histological approaches, and serum and synovial cytokines to measure the amount of chronic and systemic and local inflammation. And we also measured the gut microbiota to get an idea how that might be affected by obesity and how that might affect knee joint osteoarthritis. So we had a control group of 11 animals and started out with 21 animals that were exposed to the HFS, or the high fat sucrose diet. And then at 12 weeks, we divided these 21 animals in 7 animals that were the heaviest, and we called them obesity prone, and 7 animals that were the lightest after 12 weeks, and we called them obesity resistant, and then had them for another 16 weeks on this high fat sucrose diet, and then analyzed their joints. And so here you see an animal, and this was an obesity prone animal at the end of the 28 weeks of exposure to the high fat sucrose diet. And you can see this is a very fat rat. And then here we have an obesity resistant animal. So this animal also received the same high fat sucrose diet as this animal, but its body weight stayed lower. But as you will see, its body fat percentage also increased. And then this is a control animal that is of very similar body weight as this one, but it has much more lean body mass and lean fat because of the healthier diet that it was exposed to. So here we have some results. First, the weight of the animals in grams. So here we have the control animals, and they were about 800 grams. And the obesity resistant animals were also about 800 grams. There was no difference in weight. And the obesity prone animals, they were over a kilo. They were like 1,250 grams. So much, much heavier than these two groups of animals. However, if you now look at the obesity that we quantified with the percent of body fat, then you realize that the control animal at that age are about 30%. And the obesity resistant, so these animals with the low body weight, they are at about almost at 50%, and these are almost at 60%. So the obesity resistant and the obesity prone animals were much higher in percent body fat than the control animals. And now the question became, which of these two factors, the body weight or the percent body fat, determines the outcome of knee joint osteoarthritis? If it is the body weight, then these two animal groups should be the same, and this one should be worse because it's heavier. However, if it's the body fat percentage, then this one should be good, and these two should be bad because they both have an increased percent of body fat. And the way it turned out is that the control animals had a low Mencken score, and then the obesity resistant and the obesity prone animals had a high Mencken score that did not differ between these two groups. And in other words, therefore, it appears that it's the body fat percentage, which is similar between these two groups, that determined the amount of osteoarthritis, and not the body mass, not the weight of the animals, because these two groups are of very similar weight. So here you have the histological slides, again with a bad degeneration of the joint here, bad degeneration of the joint here, and then in the control animal, a relatively good joint. And this, of course, is a high-fat sucrose animal that was obesity resistant, and the high-fat sucrose animal that was obesity prone. So we also looked at the inflammation profiles, but I don't want to go into the details here, except that many of the inflammation markers in the synovial fluid of the knee joint, that means locally, were increased, and that many of the serum markers, that means those that indicate systemic inflammation, were also increased. And many of these inflammatory markers had high relationships between the Mencken score, or the amount of osteoarthritis, and the inflammatory marker. The one that had the highest correlation was the synovial fluid IL-1 alpha inflammatory marker that was highly related to the Mencken score in a positive way. And here we also, as I said, looked at the gut microbiota. And again, I don't want to go into the details except for saying that the high-fat sucrose animals, independent if they were prone or resistant to the body mass gain, they had a distinctly different profile from the control. And as for the inflammatory markers, many of the gut microbiota markers were significantly related to the Mencken score. For example, the lactobacilli were downregulated with obesity, and they were negatively correlated with the Mencken score. That means the less lactobacilli you had, the worse your Mencken score was, exactly as one would expect in an obesity model and the gut microbiota behavior in obese animals. So we concluded from this particular study that obesity is indeed a risk factor for the onset of osteoarthritis. And it's not the increased weight that causes the osteoarthritis, but it's the inflammation and the metabolic profile and the change in the gut microbiota that seems to be responsible for causing the knee joint osteoarthritis. There were many multiple and significant associations between osteoarthritis and inflammatory markers and gut microbiota markers. And the details of these relationships, they do need assessment, and nobody has really done that properly to date. So with this high-fat sucrose diet, we also wanted to see whether or not we can help these animals that have this bad diet. So we asked the question, can exercise or a diet supplement help reduce the onset and the development of knee osteoarthritis? So again, a very simple question. And so the way we did that is that we fed these animals a high-fat sucrose diet, but now we supplemented that diet with a prebiotic fiber. So we used an oligosaccharide prebiotic fiber to help these animals. And then in the exercise, we used aerobic exercise and strength training to see whether or not this would potentially help in the animals in reducing the knee joint osteoarthritis. And then we also had a group where we combined the diet intervention and the exercise. And so here you see an animal that is running on the treadmill, and the aerobically trained animals did that 30 minutes every day for the entire duration that they were exposed to the high-fat and high sucrose diet. And then here we have animals in strength training, so they run up the ladder here, where they have this weight attached to them, and that causes them to really have to exert a lot of force in order to get up there, and their muscles increased dramatically. And so there was a real weight exercise. And again, they did that 3 times a week for the entire duration that they were exposed to the exercise. And so here I'm going to show you some results of that particular study. So here we have the body fat percentage for the control group that I call chow. So these received the regular diet. They had about 20% in this group. They're a bit younger, so they're not quite as big. And then the high-fat sucrose animals, they had significantly higher body fat percentage, about 32%. And then here I just show you one of the groups. This is the high-fat sucrose with the aerobic exercise. But for the other, for the strength exercise and for the fiber diet intervention, the results were the same as here shown for the aerobic exercise. So the question became, what is the body fat percentage? And the idea was, because of the exercise, it would be the same as the chow animals, but it was not. it was higher than the chow animal and was much closer in body fat percentage to the high fat sucrose animals. So the aerobic exercise in these animals did not prevent the gain of body fat as we had expected. So then we looked at the metabolic profile, and as I said, we measured 27 different metabolic markers, and I'm just going to show you 3 of them here. And this is insulin sensitivity, which is reduced, as one would expect, in the high-fat sucrose-exposed animals. So they have a healthy insulin sensitivity, and they have a very, very much reduced one, which then leads to type 2 diabetes. And here we looked at the blood triglycerides, and as expected, the high-fat sucrose animals are much higher, significantly higher than the control animal. And also another marker, the blood leptin, is much higher in the high-fat sucrose animals compared to the control animals. And the question now became, what about the animal that exercised, that had the high-fat sucrose like these animals, but exercised and also have this almost a similar fat percentage as these ones? So does the exercise alleviate some of that, or because they are also fatter than the control animal, did the exercise not help? And in terms of metabolic profile, we found that exercise prevents changes to the metabolic profile in the rats fed a high-fat sucrose diet. And this can be seen here. The sensitivity to insulin is the same as in the control. The blood triglycerides is the same as in the control. And the blood leptin level is also the same as in the control, and always significantly different from the high-fat sucrose animals. So metabolically speaking, even though these animals had gained body fat much more than the control animals, metabolically speaking, it seemed they were perfectly healthy. And if you now look at the knee joint integrity with the Mankin score, then we show that the control animals have a score of about 19. The high-fat sucrose animals have a score of about 50, so much, much higher. And now the question became, what about the animals that had the high-fat sucrose diet and the exercise? So they are still much fatter than the chow animals, but they have the same metabolic profile as the chow animals. So in terms of body fat percentage, they are like these animals, but in terms of the metabolic profile, they're more like these animals. And as it turned out, they actually had a Mankin score that was significantly lower than the high-fat sucrose animals alone. So the exercise prevented the osteoarthritis development in these animals and left it about the same, in fact, even slightly lower than in the control group. So the hypothesis was that exercise prevents OA-like changes in the knee joint of rats fed the high-fat sucrose diet, and this hypothesis was accepted. Yes, indeed, exercise in this group prevented knee joint damage. So we see some slides here. This is a control animal with a beautiful histological joint. This is a high-fat sucrose animal with a bad joint that is disrupted, and the meniscus is disrupted. And then here, this is an example of a high-fat sucrose animal that received the exercise. And these 2 joints here of the control animal and the high-fat sucrose animals were essentially indistinguishable when you looked at them. So we learned from this particular study that obesity, as quantified by the percent of body fat, is a risk factor for knee osteoarthritis, but weight is not. Also, obesity is associated with systemic and local inflammation and changes in the gut microbiota, and exercise and nutritional intervention, particularly the fiber diet intervention that we used, prevented knee joint osteoarthritis in this particular animal model. So we concluded from that obesity is associated with metabolic disturbance, that obesity is a risk factor for knee osteoarthritis, and not only for the bone and joints, but it also affects muscle performance, which I did not explicitly show in this particular presentation, but it does. And exercise can offset some of these bad or maladaptive events of obesity, and so can a diet that is high in fiber, that supplements the high-fat sucrose diet. So In summary, we have these systemic contributors to metabolic osteoarthritis that is induced by a high-fat, high-sucrose diet that leads to obesity. So let's start here with our adipose tissue, where we have fat cells here that contain some macrophages. And when it's exposed, when we are exposed to high-fat sucrose diet, what happens is that these fat cells become bigger and the number of macrophages increases. And then when we continue doing that, then the adipocytes or the fat cells become stressed out and they release adipokines that then cause muscle fibrosis and cause metabolic osteoarthritis in the knee joint. If you look at the gut microbiota that we have here, the intestinal cells, and here you have the gut microbiota, when the gut microbiota are exposed to a high-fat, high-sucrose diet, what happens is, what we observed is that there's a permeability that happens in the gut here, and so these microbial cells and these bacteria can leave through the intestinal permeability and go into the host system. And particularly, we observed lipopolysaccharide translocation from the inside of the gut into the system. And then this lipopolysaccharide, they stimulate the fat cells and stress them out. And we have, again, the same fibrosis and joint degeneration as we had before. And also, the lipopolysaccharides seem to have a direct effect on joint integrity and therefore cause joint degeneration in a very, very direct way. So we think what we have done with the fiber diet intervention, we inhibited this particular pathway. So we inhibited the leakage of the gut and the leakage of lipopolysaccharides into the system, and therefore the stimulation of the fat cells and the fibrosis and osteoarthritis in the joint. And with the exercise, we think we directly influence this pathway where the adipocyte stress was reduced, and therefore we didn't go in this particular way to muscle fibrosis, fat accumulation, and to osteoarthritis of the knee joint. So we think that both of these interventions, the fiber diet and the exercise, had the same effect, that they didn't cause and that they prevented knee joint osteoarthritis in animals that were fed a high-fat sucrose diet. But we think that the pathways are actually distinctly different in how that was achieved in this particular model. So, coming back to the very beginning, I have the outline here that I showed you at the beginning of my talk. I wanted to talk about osteoarthritis and the many causes that osteoarthritis has and the many risk factors. And some of them, not all of them, are listed here. I talked about the ones that are associated with modifiable factor. We can modify post-traumatic osteoarthritis. We can prevent injuries if you're careful. We can prevent muscle weakness and muscle imbalance by appropriate exercise, for example. And of course, we can prevent obesity and metabolic syndrome by appropriate diet, by exercise, by proper eating habits and the proper lifestyle. So these are the three causes of osteoarthritis that we have studied and that I wanted to talk about. But of course, as I said, there is also some factors shown down here that are not directly modifiable. And then, of course, there is other causes of what might be causing osteoarthritis. But the message that I wanted to get across here is that people have osteoarthritis. 1 of 5 people in Canada has osteoarthritis, but the way the osteoarthritis comes about might be very different, and therefore the way it has to be treated or has to be approached or might be prevented also has to be different depending on what is the cause of the osteoarthritis. So with this, I come to the end of my talk, and I would just like to briefly acknowledge Tim Leonard and Evelyn Hasler, who were primarily responsible for doing the work that I showed on post-traumatic osteoarthritis. And then I would like to acknowledge Raphael Fortuna, David Longino, Cy Frank, and Christian Egloff, who were primarily responsible for the results that I showed on the muscle weakness and muscle imbalance. Please note that Raphael Fortuna originally was from Porto Alegre. He's still now in Calgary, not with me, but doing a postdoc with a postdoctoral fellowship with one of my colleagues. And then also I would like to acknowledge Kelsey Collin, Jacqueline Rios, Ruth Saraten, and David Hart, who were primarily responsible for the work that I showed on the obesity and metabolic syndrome model. And again, I would like to acknowledge specifically Jacqueline Rios, who is from here, Florianopolis. She was a graduate student at Udesky and then did her PhD with me, finished up about a year ago, and now does postdoctoral research in the Netherlands, in Europe. So with this, I would like to thank Alessandro Aupenthal once more very, very much for a very kind invitation, and hope that you might have learned something from this particular presentation here. Thank you very much for your attention.